and welcome to what has become an annual fall program on a topic of geriatric interest. Thanks to Jane Marks, who is the director of the Johns Hopkins Geriatric Education Center. And every year we put our heads together and come up with an interesting topic and invite speakers from Hopkins and other places to come down and enlighten us on various geriatric issues. So this year we decided to take a panel approach. Of course, the evening's program is entitled Breaking Down the Silos of Collaborative Approach to Caring for Older Adults. And I now will turn the podium over to Jane Marks. I'm Dr. Mary DiBartolo, by the way. I forgot to introduce myself. I'm a nursing professor here at Salisbury University, and I will now turn the podium over to Jane Marks, who will introduce our esteemed panel and get the evening going. Thank you.
Thanks, Mary, and thanks for having us. I'm a nurse in the Division of Geriatrics at Johns Hopkins Bayview, and our program tonight is supported through our Geriatric Education Center. So I appreciate you doing the forms that I distributed. Our first panelist member who I'd like to introduce and have him say a few words is Dr. John Burton. Dr. Burton is a professor of medicine at Johns Hopkins University School of Medicine within the Division of Geriatrics and Gerontology. He is also involved in our Geriatric Education Center and is still involved in primary care practice and making home visits to patients in the community. So it's very appropriate with his background in geriatrics as well as his national involvement in programs for older adults that he's going to address a little bit about the overview of geriatrics and history and how we've come to where we are today.
Okay, thank you very much, and thank you all for being here. I trust these microphones are on and working.
Can you all hear?
Okay, fine. Let me just start off by thanking you for being here and tell you my view of this is that this decade we are now entering is perhaps the most exciting decade in healthcare delivery in the last 100 years or so. And I say that with all seriousness. These are times of great change and great opportunity. The title of this seminar is Breaking Down the Silos. That is a critical responsibility of all of us in healthcare. These silos that have been built of physicians doing this, nurses doing that, pharmacists doing this, no longer works. It's now an era of team care and team organization. Why is that so important? It's important because of the exciting demographic changes that have happened in the United States in the last 50 years. Primarily the ever-increasing growth of the aged population. By aged, older, I mean 80 and above, or 85 and above, in that range. That's the population in this country that's going to double in the next 25 years. That's the population that consumes about half the healthcare expenditures. They fill more than half the beds in any hospital, and they account for more than half of most surgical operations in the United States. They're a very special population of patients, and we're just now beginning to figure out why they are so special. In my view, to make it simple, they are special because we are in an epidemic of chronic disease, and when you get into your 80s and above, invariably if you have accumulated not one or two, but often 10 or 12 or 13 different diseases. So the care of someone with multiple chronic diseases is far more complicated than caring for someone with one or two. Second sort of defining issue is the loss of physiological function. Physiology in your body changes. You get better and better after birth until you get to this physiological zenith. Many of you are on your way to this zenith. It occurs in the late 20s, early 30s. And then physiological deterioration occurs in virtually all systems. Doesn't mean much until you get into your mid-80s, when on average you've lost so much reserve that you're extremely vulnerable. That vulnerability, coupled with multiple chronic diseases, makes an older person very different from another older person. We call it heterogeneity aging. So these defining issues are multiple chronic problems, loss of physiological reserve, and heterogeneity. That's as complicated as it gets, and in my view, the reason why team care is so essential. Nurse, physician working together, social worker, pharmacist, all part of the team because there's so many complicated, incredibly difficult decisions. And we're about to change the way we deliver health care. We must change it. It does not work for this vulnerable population in the current climate. So you all are entering your careers at exactly an ideal time when the history of this era is written, because you will be the agents of change. How can we take care of this vulnerable population in a better and a more effective way? So most exciting times. Welcome to the healthcare professions, and I hope you enjoy your next decades and contribute mightily to the future so we do it better during your watch.
Thank you, Dr. Burton. Our next panel member that I'd like to introduce is Joanne Coleman. Joanne is a doctorate of nursing practice. She's a nurse practitioner. She's certified in oncology nursing. She works in the acute care at Sinai Hospital in Baltimore, and she's actually the clinical program coordinator for Sinai's Center for Geriatric Surgery. So imagine now, there's even a specialty, geriatric surgery. And Joanne's going to talk with you a little bit about how the team approach has impacted her care, but also a little bit about acute care and how things have changed.
Thank you, Jane, and thank you again for having us here, and I'm delighted to be here. First time I've ever been to the Salisbury University. So my perspective comes from the inpatient acute care perspective on the care of the older adult. And like Jane said, there's now a specialty for geriatric surgery. You're also, you'll be hearing more about geriatric emergency medicine as well as geriatric trauma centers. So now we've gone from like pediatrics to geriatrics as specialties within the hospital. And hospital is just, the acute care is just one part of the, continuum of care in these patients. And like Dr. Burton said, we have to consider the whole physiologic changes that the older adult goes under. And now you have to consider you're going to be putting them through a major insult like a surgery. So there's lots more to consider. And there's a number of principles of geriatric surgery, but I think the one that really sticks in my mind all the time is that older patients can tolerate major surgeries. They can't tolerate the complications. So what we need to do is do a better assessment of these patients preoperatively and postoperatively. So as part of this, what I do is a number of different assessments on patients, thinking of the holistic person, from the cognition to the functionality to nutrition to different kinds of pulmonary evaluation, cardiac evaluation, fall risk assessment, delirium assessment. As Dr. Burdick said, 50% of the patients that we're seeing in surgery are 65 years and older. And the fastest growing population that we're seeing in surgery is 85 years and older. So I once worked with a surgeon who wouldn't operate on anybody older than he was until he started getting older. And the older he got, the older his patients got. And then he finally operated on a patient who was 103, documented. And she did well through a major abdominal surgery. And I think the other thing is, we think that people can't go through it but just by looking at them, like the eyeball test, but that's not always considered valid these days because they may look good, but they may not be that good in functionality and cognition and vice versa. So we really need to take each person as a unique individual when we're assessing them and when we're taking care of them. Patients coming in for surgery particularly need not only excellent assessment with the history and physical and their labs and their imaging, but lots of other things as well. Particularly hearing, oral assessments, big these days, different things like that you have to consider. And therefore, not only do they need good assessment preoperatively, they need excellent technique during surgery as well as a good anesthesia evaluation to make sure that we're going to put these people to sleep and make sure that they wake up. Now, that's one little period in their hospitalization, but then afterward, it's actually the nursing folks and everybody else who's going to be taking care of that patient who are working together to help get that patient through their hospitalization, through their surgery, with the best possible outcomes, with quality care, and make sure they get back to a functioning individual and hopefully back to where they came from. So that doesn't happen all the time, and the only way we do this is working together. And like we have pharmacy that helps us, social worker, the nutrition folks, occupational therapy, physical therapy, all this interacts with the patient. So nursing alone doesn't do it, I can guarantee you that much. And we work closely with everyone so that everybody's on the same page through the continuum of care, and you'll hear transitions of care as the other buzzwords these days. Very much interacting and having almost daily rounds with the whole group to see where our patients are and where they're going to go, and so that hopefully we get them out of the hospital back to the functioning person that they were and doing the best that they can. Also, older folks really want quality of life, maybe versus quantity of life. So we want to make sure that the surgery that we're doing on them may not be the most invasive study, but maybe a less invasive that also maintains a quality of life. So also considering what does the patient want done. That's a big question that I ask all my patients, and I only see patients who are 75 years and older coming in for any elective surgery, and that's one of the questions that I ask them to make sure that they truly want the surgery. And this is all just happening right now. We're a very new service. We're the only center that you'll find for the Center for Geriatric Surgery that we know about in Maryland for sure, and there's newer ones cropping up. As a big paper came out in October of 2012, which was a collaboration between the American College of Surgeons and the American Geriatric Society for best practices guidelines for the preoperative assessment of the geriatric patient. And so people are now starting to institute this so that we can assess the patient ahead of time so that we can do prophylactic, preventive measures, and also, before surgery, and also we're looking at caregiver. So caregiver burden is a big thing that goes along with a lot of these surgeries. So once again, dealing with the whole collaborative group, that it's not in silos anymore, like Dr. Burton said. It is definitely a team approach to taking care of these patients and making sure they have the best post-operative outcomes. So I also work with the critical care folks, with the emergency room folks, just making sure about this, looking from the geriatric perspective in the care. And there's different things that are coming out, and you'll find out different guidelines are coming out for these patients. So I think that the geriatrics is on the edge of just bursting forward, or it is bursting forward in the care of the geriatric patient, of which, hopefully you will consider going into that because it is fascinating, and I have more fun with these patients than with anybody. So hope you all will enjoy this panel and get some information and ask us some good questions.
Thank you, Joanne. Our next panel member is Tom Siska, who wears, I think, many hats down here on the shore. Tom is a professor of pharmacy practice at the University of Maryland Eastern Shore School of Pharmacy. He also coordinates the Anticoagulation Center at Shore Health and works with patients and the team, I think, many times in managing a patient on anticoagulation therapy. So Tom is going to talk a little bit about his role as a pharmacist and how it impacts working with the team and caring for older adults.
Thank you, Jane. I told Jane when she invited me, I said, well, how many slides should I bring? And she said, no slides.
No slides.
So I have to do this off the cuff. But I came to the shore in 1972, and I thought I'd stay a couple years and move on to something bigger and better, and best decision of my life was to stay at that time. And when I came, I was the first PharmD, as they say, on the Eastern Shore, and my area of interest was drug interactions, drug therapy, and cardiology, so those were my focus. And over the years, that's primarily been my focus. But the main concern that we have in the elderly is the consumption of medications, the aging population, as Dr. Burton mentioned. And one little number I do have is that by 2030, which is not far away, we will have over 71 million population based over the age of 70. So I just turned 65 this year, so I always sing to my 3 sons the song by the Beatles, Will You Still Need Me, Will You Still Feed Me When I'm 64? Because there's a lot going on there. And that population base consumes 30% of our prescriptions. They are the largest consumers of over-the-counter alternative medicines. There was a review article in New England just last year looking at adverse drug reactions as a cause for hospital admissions, and it was the number 2 cause for ER visits and hospitalizations. And I think what a lot of people don't realize is that death and morbidity due to adverse drug reactions is higher than the combined death of cancer, heart failure, and lung disease, and even automobile accidents. So if we look at the problem, it's growing, and our population as we age is growing. Every disease that we have, polypharmacy, polymedicine, if you come in with diabetes, if you come in with heart failure, if you come in with a heart attack, you will go home on 4 to 6 medicines just for that new diagnosis. And I would tell you, the literature says that once you get over 5 medicine, especially in the aged who have slow kidney function, liver function, there's at least a 50% chance of a drug-drug interaction that'll occur. So my focus with antithrombosis, you can imagine warfarin or Coumadin. You can imagine, as the students here I'm sure are starting to learn, all the potential drug interactions with that, the monitoring that needs to be done. As we get frail, we fall, the concerns of intracerebral hemorrhages. So there's a lot of issues with medications in the elderly. My focus has been cardiology, now managing antithrombosis center. I have about 900 outpatients that I follow. And it is a team effort. The doctors refer the patients to me. We're talking about breaking down silos, but I am still more of a specialist than in a patient-centered practice right now. But we are developing that both at the school, and we have examples of actually faculty members that are here in Salisbury. I think it's called TLC. We have 3 faculty members that are working with that whole group in a team-based approach. And we have our students actually go there. But my center is I manage patients on warfarin and other antithrombotic therapy. We round every day in the hospital. But our main thing is continuity of care. So I know every patient who is admitted, what their INR is, why they came in the hospital, what they went home on. And I'm always shocked when I see the discharge summaries that come to me. This is the mean number of medicines that my patients go home on is 14. And last week, just looking for this talk, I had 28 and 32 medicines that patients went home on. So believe me, I need nurses and social workers and doctors and everyone to be helping our patients, because the concern with the elderly is as we get older, as I know, our arms get shorter, we can't read the labels, we can't understand all the issues. So the elderly really needs help in understanding all these issues and how to manage them. And over the years, I've done a lot with just trying to do stuff with reducing the amount of medications patients are on. So we call it brown bag. We do interprofessional discussions with nurses. We have team efforts to try to look at the amount of medicines you're on and ask the question, do you need to continue them? So that's my area. I think I'll stop there and then look for questions in that area of drugs, drug interactions, cardiovascular medicines, and pharmacy.
Thank you, Tom. I know just from a clinical point of view with our anticoagulation center, we're always working with him with medicines and trying to avoid adverse drug reactions. So we're glad to have you around to ask questions. Our next panel member is Dennis Klima. Dennis is a physical therapist. He received his bachelor's degree from the Medical College of Virginia and his PhD in physical therapy from Temple University, where his dissertation focused on physical performance and fear of falling in older men. He also is a geriatric clinical specialist in therapy, as well as a neurological clinical specialist. So Dennis brings to the table, I think, the team effect of working on maintaining function in older adults and his role in keeping that going.
Thank you, Jane. Thank you very much for inviting me here. When I look out at the audience, I have to tell you that the nursing students have the best posture of anybody out there, even at 7 o'clock in the evening, and that's good to see. With this older adult population that we're working with, it's so important to exercise, and that's something in this time that we just have to keep older adults very active, very fit, walking with community-based walking programs. If we could do a little drill here, this section of the room, the young bucks over here, if we could have you stand up, okay? Just stand up and shoot up. Good, and then have a seat. Okay, look how fast that was. They just shot up there. Now, over here, you all are going to be the 90-year-olds, okay? So let me see at the age of 92, stand on up. Yep, stand on up as if you were 92. Dr. Seldom-Ridge, always a ham, right there. Okay, and have a seat. Thank you. You know, that doesn't have to happen. And one of the important strategies that we really do work with older adults is with leg strengthening exercises. This really is an exciting time for physical activity because we see more and more older adults going to your own gyms, World Gym, Powerhouse, but also we're seeing specific medical gyms arise where folks can go to cardiac rehabilitation gyms. And also this year in the United States, we saw many gyms open specifically that are termed diabetic gyms for folks with diabetes. So that's really been an excellent initiative. One of my very own passions is fall prevention among older adults. And this is something that's been excellent because it's a wonderful area to work with other professionals on. I've had the privilege to work with your own Dr. Tina Brown-Reed with the Stepping On program over at the MAC Center. It's a community-based program, 7 weeks, where the nursing students take part doing the medication assessments, and also they go to the home to do fall risk assessments for the participants in the home. They come back and they communicate that to the physical therapy students to target specific areas, both with intrinsic and extrinsic causes of falls, to strategize for fall prevention initiatives. Jane had mentioned that while more older females do fall and fracture, specifically that hip, interestingly, more older men die from a fall. More older men tend to fall from heights, and it really is a problem. We know that 1 in 4 veterans that sustains a fall over the age of 65 will be dead within a year. So the statistics are pretty compelling. One of the other initiatives that we've been doing just with exercise, we've been getting teams together of multiple professionals and sponsoring activities in the senior centers across the Delmarva so that we can do both fall prevention initiatives, exercise programs, and work as an interdisciplinary team. Our motto really is with physical therapists, we want to keep you fit, we want to keep you happy, and we want to keep you vertical. So, but we really, this year, in your own department, I know that Dr. Katie Hinder has really made just a great initiative to pull both Salisbury University and University of Maryland Eastern Shore together with the health disciplines to break down these silos so that we can all keep older adults living longer and healthy and walking. Thank you.
Thank you, Dennis. And I truly think, with my interest in falls over the last couple years, working with Dennis too, it really has become a team approach, looking at all the things that he talked about. Function, looking at medications, looking at chronic disease and impact. So I appreciate your insight into that. Our last panel member that I'd like to introduce, and I think one of the most important people on our team, is our social worker. Cheryl Sinkbell works as a social worker for the MAC Center, which is Maintaining Active Citizens, which is a AAA center here in Salisbury under Peggy Bradford's guidance. Cheryl's role now is an ombudsman, which she advocates for people in long-term care and assisted living. But also the MAC Center, I think, is very creative in all that they do for people in the community as well. And just to remind you that most older adults live in the community, not in nursing home and assisted living. So her role is unique, but she also brings with her a vast amount of experience. And I have to tell you, she's also a graduate of this college. So thank you, Cheryl. If you could enlighten us a little bit about team approach with the social worker's perspective.
Okay, so I'll tell you a little bit about MAC. Sherry told you what it stood for. I was going to test you on that. You gave up my answer already. But if people don't know MAC, it does stand for Maintaining Active Citizens. And, you know, we are the designated area agency on aging, but we also already have a partnership right there. We have BASIL, which is the Bay Area Center for Independent Living. So we're actually an aging and disability resource center. Right here, we serve 4 counties: Dorchester, Somerset, Wacomico, and Worcester. And 94% of the people we serve do live in the community. Our goal is to keep people at home as long as possible. Now, most people that know MAC at all, they know us for Meals on Wheels and senior centers. They're probably the 2 big ones, right? They know what MAC stands for. And they're very important programs. But we have lots of things under the MAC umbrella. We have advocacy and assistance programs. We have a caregiver resource center. We talk about caregivers needing help. We have a wellness center. Dennis mentioned about keeping our seniors active, and we have an absolutely beautiful state-of-the-art gym. And you got to be 50 or over to join. See, you got to be 50. I was happy of that. And we have a lot of health and fitness programs like yoga, Tai Chi, Zumba. Well, it might be Zumba Gold, but it's all modified a little bit. Aquatics and the chronic disease programs. We have classes to help people deal with their chronic pain, diabetes, fall prevention you mentioned. We have programs, Stepping On, Matter of Balance. Most of these classes are 6, 7, or 8 weeks long. We have a lot of in-home services, again, the nutrition, the senior centers. We have a day center for the memory impaired. We have volunteer services. We have just lots of programs. And I have some brochures for you if you like about our MAC services. Under MAC, we also have MAP, M-A-P, which is Maryland Access Point. And the idea is, you know, you get bombarded like, where do I go for help? You know, the idea is, can there be a single point of entry, like a one-stop shop for our seniors, so they don't have to like go so many places to try to get help? And that's what MAP does. MAP stands for Maryland Access Point, and it really is that one-stop shop to help aging adults and individuals with disabilities of any income level, doesn't really matter, but help you get needed information and assistance about all kinds of things. Long-term care services, how to plan for your future. It might be about Medicare Part D. It could be a lot of things. We see family members and caregivers who are trying to support a parent, a spouse, an adult child, and how they can also receive assistance because they need resources. What I do as the ombudsman, as Jane mentioned, is I'm a residence advocate for the other 6% of the population who lives in nursing homes and assisted livings. For years, I've seen that care plan team approach, right, within long-term care, where you've got the nurse and the social worker and the physical therapist, and dietitian, activity director, all working together, get together weekly to have care plan meetings for those especially who live in nursing homes. What I'm seeing even more now as the ombudsman, I'm seeing a lot of younger disabled people in facilities, as well as the old, as you mentioned. I've had people over 100. It's not unusual to see more than one person now, between 100 and 105 at a lot of my facilities. And what I'm seeing more now is a push of working together with other agencies to get them out of the nursing homes and back into the community. Waiver programs, group home subsidy programs, VA programs. We work closely, you know, as MAC, we can't do it all. Our budget gets cut, funding gets cut, we need help. And we work closely with the local health department, the VA, AIRS, we call it Adult Evaluation Review Services, hospice. There are so many other agencies that we get to partner with. Also BASIL, like I said, to help our residents because we can't do it alone. Families need support, the residents need the support, and we have to help each other. And it's a great partnership. Literally had a case today that involved the hospital, mobile crisis team, and assisted living, MAC, Medicaid waiver program, and I think I'm missing one. There was at least 6 different agencies I talked to today with one case today. And we all have to help each other, you know, and work together. A lot of times, put our resources together to come up with the best idea. And the idea is to have the people have quality of care and quality of life, whether they live in their own homes, that community, or also live in a nursing home or assisted living. So
I consider it a privilege and an honor to be able to be an advocate for people in facilities.
Thank you, Cheryl. I think you hit some key words there, maintaining their quality of care, quality of life, and giving them the optimum care that we can. And certainly that team approach helps with that. I'd like to open the floor to questions that perhaps you may have for the panelists, that we could open a dialogue between you and I and them. So does anyone have a question? If you'd like to, if you could come up to the microphone, it would be great.
What we did is we have a lot of our junior level nursing students here, and for part of their assignment for our adult med-surg nursing course, theory course, we had them all bring questions. And so Dr. Seldenridge and I went through mostly all of them to pick out some of the questions that might be of interest that you can answer for us. I guess some of them, I wanted you, Jane, to talk a little bit more about transitions of care, which someone on the panel mentioned, and how we can really optimize those transitions of care for older adults from the hospital back to the community and keeping them there. What are some of the approaches? And then what would be some of the challenges to doing that, especially in our society where, unfortunately, ageism still does exist?
So, transitions of care is kind of a hot term where the patient is moving from either within the institution that they're in, perhaps they're transferred from the critical care area to a regular unit, and then maybe out to rehab for a short stay, or maybe a subacute unit, or maybe assisted living. And the goal is to how to provide information about what's been going on, what medications perhaps that they've been on and changed, and what happened at home, what was going on before home. And so the goal of that is to provide that smooth transition communication. And there's really several things going on that's exciting related to nursing, I think. One is I've been involved in the national effort for guided care nursing, which is a program that's recognized by the American Nursing Credentialing Center. We've just re-edited our test exam last year, and it's a module-based program where a nurse actually works in a practice, primary care practice, with a team of physicians, social work, pharmacists, therapists, and she follows the more frail patients. And so she kind of troubleshoots for them, but she actually follows them through that continuum. So if they would go to the hospital, she'll go in and meet with the team. She'll talk with them, she'll review the goals of care, she'll review what was going on at home. And then as they move through the system, whether it's within that institution or to another one, she follows them. And then she will even follow them at home then and coordinate that care perhaps with a home care agency where nursing comes involved. She'll work with them. The physical therapist may come in, the occupational therapy. So guided care is something that's came out, I guess, around 8 or 9 years ago. Dr. Bolt was the physician who developed the model and worked with Johns Hopkins School of Nursing and our National Gerontological Group and developed that. So that's one model of care that I think is exciting. There have been a lot of different models looking at transitions of care, and some of those have been funded through the innovation practice model at Medicare at CMS. And I know at Hopkins we have a program now called JSHIP, which they are working with coordinating care and following patients through a primary care practice as well as if they go to another facility and working with that coordination so that we can avoid those adverse drug effects that Tom talked about, which can lead to complications, so that we can maintain that function, know where they were before they went in and try to get them back to that point. And then work with social worker to find out now all the community programs that are out there. In January this year, Cheryl can reinforce some of this, but Community First program rolled out. And so it opened up the door to community much more so. And through Maryland Access Point, the idea was to help make one call for that family or that patient to tie into multiple services they were eligible for, instead of having to call each agency. So a lot of things that are out there, and this is an exciting time, I think, for all healthcare professionals, because there's new models, new creation, and you can be part of that. So a little bit in the tidbit there.
I
Mary?
guess going off of that, we had another student ask about what are some of the particular challenges providing optimal care to older adults in rural communities, of which we are here on the Eastern Shore.
I'm sorry, in the community?
To providing care to older adults who live in rural areas.
Oh, in rural
Rural
areas.
areas, yes.
In rural areas. Anyone from the panel would like to address? Cheryl, maybe you may have more experience than probably most of us.
Well, we're definitely a rural area, no doubt about that. I have some assisted livings and stuff. We're just really in the country. And what I was thinking with your last question, too, was that I have a coworker at MAC who every Wednesday, she goes to PRMC. She spends the day at the hospital and works with the social workers as like a nurse. She's a senior herself, retired nurse, and she goes to the hospital one day a week, and they work with those that are going to be discharged soon, so they can talk to them about what they'll need when they get home, and how can we make it so they're not going back to the hospital? How can we stop those repeated readmissions, right? Because nobody wants that. And what can we do to educate about medication? About do they need a ramp? Does the caregiver need to go to support group? I mean, what's out there that can help them so that when they go home, it'd be a successful discharge? And it might be that transition from home to a rehab setting. Nursing homes not like they were 30 to 40 years ago. A lot of people go for a rehab and then go home or go to an assisted living or go back to a lower level of care, which is what the goal really is. And there's a lot more programs out there to do that. I think it's a challenge, and our biggest area of concern I think we have is transportation. It's really hard, especially in the rural areas, for transportation. And then a lot of times the caregivers can't leave their loved one. I can't go out and do things unless someone takes care of my loved one while I'm gone. They need that respite care. They need to know what's out there, and there are programs out there, but a lot of times it's a matter of giving the information and assistance they need. And a lot of times people are afraid to ask. I'll be honest with you. A lot of times our seniors and caregivers are very strong and very independent, and don't like to ask for help. And a lot of times I find the children, the ones that come in and ask a lot of the questions, and what can we do for mom or dad? But it is a challenge in the rural area with transportation. I think, limited funding and resources. We live in an area that most people were, chicken growers and farmers, and not as highly educated, and their income levels are low. And it's a challenge to meet their needs. They're trying to live on their Social Security per month, and they can't do that. It's just not enough.
And I will tell you, even in the city, transportation is still an issue for older adults. So, they can, if they're able to use public transportation, great, but transportation is a huge issue when we're looking at senior care. There was a question in the audience. Did someone have one? Go ahead. I'll repeat it if you can.
Can you repeat the question, Jane?
All right, so as a student, what can you tell us that would enhance our attraction into going into geriatrics or gerontology or nursing?
So as a student, what can we tell him that maybe attract him to geriatrics or gerontological nursing? Joanne, you want to start? You have come through the ranks here.
I'm happy to comment on that, and then Joanne. To me, it is by far the most exciting part of medicine, and I say that not having been a geriatrician all of my life. I came to geriatrics after specialization, and it is the most exciting because of the patient population, wonderful population, very appreciative people, yet very complicated, so it requires kind of the best of your skills, the best of your old-fashioned skills, communication skills, sensitivity, and compassion, with the best of modern science, because you've got to put the two together if you're going to get it right. I think also you don't have to be going into geriatric medicine or gerontology. Unless you're going to be doing obstetrics, you're going to be doing geriatric medicine. Geriatrics dominates the healthcare system by far, and it's only going to get more dominant in the years. So everybody, I think, needs to embrace the cardinal principles of geriatrics.
And I agree. No, it kind of, when I started out, I was going to do surgery, and not in the operating room, but take care of patients with surgery. And just over the years, you just realize that, like I said, more and more patients were older, and And they do require the time and the compassion, but they're the population that like listen, I think, and they're like very, very appreciative of what you do. And they're not seem to be in a hurry all the time. And it's just a different kind of feeling that you get. And I never thought that I was going to go into geriatrics per se, but I just realized that it touched us everywhere in the hospital, no matter where you went. And that, you know, those were the people that I enjoyed the most taking care of, and that I felt helped fulfill me as well as hopefully help them as much. And you really get to know them, I think, better, and then their families. And then I did oncology, surgical oncology, which is either another kind of specialty, but that's another special population. Particularly, the older you get, the more likely you're going to have a cancer. So if you think about that one, so it just kind of meshed. And then I went and did my doctorate in the preoperative assessment of the older adult having surgery for cancer. So it all kind of came together, and I was golden in acute care, oncology, geriatrics, you know, advanced practice nurse. I could go anywhere and give talks in this aspect. So it actually opened up a whole new prospect for me in different areas. So that's why I enjoyed it so much.
Jane, perhaps I could make just another comment, because I think it's a critical question. And to me, there are two additional comments I would put before you. One is the demand for judgment. So if you want to enter a discipline where you can follow templates, geriatric medicine or geriatric surgery is not it. It's all about knowing the individual human being and their unique constellation of difficulties. And that requires extraordinary good skills of any clinician, nurse, physician, social worker, etc. And then you have to make a unique judgment. It cannot be what the textbook says, because it's far too complicated for that. And that judgment part of it, to me, is incredibly exciting and very rewarding. Patients want to work with you to make a judgment that's right for them, surgery or no surgery. You can't simply take an 85-year-old person who has abdominal pain and run them through a CAT scanner, because they have other problems that could be harmed by doing a CAT scan. So you have to think through those things. To me, that's a great joy and excitement. The second thing I would say is geriatrics, by far, is in the lead in terms of group care or team care, by far, because the component members of a team, nurse, physician, pharmacist, social worker, therapist, physical therapist, etc., the team is more valuable than the component parts. So I'm a better physician, for sure, because I have the opportunity to work day in and day out with Jane Marks and other specialists. And the patient gets better care. You stay alive and active and challenging one another. So the team care, to me, is an exciting part of the future of medicine, along with the judgment.
Thank you, Dr. Burton. There's another question out here.
Question?
I'm a family physician in Princess Anne, and my question is the topic of advanced care planning and medical directives. Most of the older patients in my practice, and I think this may be my fault, don't have advanced care plans and don't have medical directives at the time when they are probably the ones that need it the most. And I'd like to ask Dr. Burton how he broaches this topic with his fellows, and also if they have people at MAC that can help people with advanced care planning.
So the question was about advanced care planning, and Dr. Burton, he wanted to ask you that first.
So the question relates to advanced care planning amongst older folks? Is that more or less the question? Yeah, advanced care planning is simply something that each of us could do and probably should do. What do you want in the event of some catastrophe? most young people don't think about it because you have no mortality looking at you. It only happens when you get older and you begin to say, gee, I got to think about this. So making advanced directives, and there's an enormous effort, and Maryland, among the states in the nation, has been one of the states in the lead, if not the leading state in terms of advanced directives, and now a new program called MOLST. I forgot what that stands for, but it's sort of an advanced directive for very vulnerable, frail people that is focused on the focused primarily on helping emergency medical people.
For life-sustaining
Treatment, that's it.
Yeah, thanks. Yeah, but how do you do that? Most people don't want to be talking about advanced directives because it sort of begins to talk about their vulnerability and their frailty, so there's often a lot of pushback. So it's a process. It's one of the joys of primary care here and one of the joys of team care. So that Jane and I are working on this all the time with people, trying to help them begin to think about what if, before you get to that period when you're really up against a crisis. What would happen? Would you want to have a major operation? Would you want to be resuscitated? Would you want to be artificially fed? Very difficult, complicated questions. But in our practice, it's done over time unless you're in a crisis. And you begin to help the patient and the patient's family come to some thoughtfulness about this and then make a formal declaration. It's very simple to do once they get their mind around the issue and say, well, of course, I don't want to have artificial feeding. But each one of those issues, life support issues, ventilator support, nutritional support, renal support, on, and there'll be more in the future, take time and thoughtfulness and have to be presented in a very sensitive, compassionate, and understanding way. We are fundamentally advisors and educators of patients, not benevolent dictators. So you have to know the patient, work with them over time to ultimately complete these forms so that they're happy with what they have decided will happen if a catastrophe occurs.
Cheryl, did you have a comment?
Yes, part of my role as the ombudsman and part of my privilege is to also help families, individuals talk about advanced directives. Had done this as a social worker in nursing homes. The ideal situation would be to have, to go to an elder care attorney and sit down and kind of do everything. Do your will, living will, estate planning, everything. But we see a lot of people that can't afford, to go to an elder care attorney. And there are some forms on websites. There's 5 Wishes. There's the Office of the Attorney General's got forms for advanced directives that are recognized in Maryland. The MOLST, like you said, is fairly new, the Maryland Orders for Life-Sustaining Treatment. I think only about 20% of people I hear have written advanced directives, so we have a long way to go. Several years ago when there was the Shivo case, remember that, the young person? And we got lots of calls for about a month. Like, I was mailing out forms left and right to people who wanted to do their advanced directives, and then after that it just stopped again. So it is something that's a continuing situation, but we're glad to help with the information, tell people do their advanced directives. They don't have to be notarized in Maryland. They just be witnessed by 2 people that are not being named. And actually at MAC, we're going to be having a half-day seminar on this topic on October 24th. It's a Friday. It's $10, very reasonable, a couple CEUs from 9 to 12. And we have a couple speakers coming talking just about this, about advanced directive seminar. So we'd love to have you.
Thank you, Cheryl. Any other questions from the audience? Yes, Renee?
Dr. Burton mentioned the importance of relationships between patient and professional. And I can't help but think about the importance of relationships between the patient and their caregivers, whether they be professional with 4-year and more advanced degrees, or whether they be well-meaning neighbors, husbands, wives, other family members. And I'm wondering if you, just one more comment on that. some of the most intimate relationships and the relationships filled with the most information that would be useful in the care plan are those between the patient and the CNA, the GNA, or a family member who serves as confidant in addition to caregiver. So my question is whether you are aware of models of teamwork that include that CNA or include that caregiver that we don't normally think of. We can get as far in our teams as the primary caregiver, but what about the other ones that might hold valuable information? Can you cite some models or examples you've seen?
So I'm going to ask Dennis maybe to address a little bit about function and physical therapy. Dennis has been involved in our program the last 3 or 4 years educating CNAs and GNAs about function and mobility, but with his clinical experience, Dennis, and working in a rehab facility that you do, your involvement in working with them in reference to your approach to the patient.
Yeah, I think I work at Kernan Hospital, Umroy, every week as a per diem therapist, and we've seen over the past year new interprofessional team models occurring as an extension of the care plan, where both nursing assistants and family members are brought in to discuss the progress of the patient. The other thing that they're doing are just now informal huddles, they call them, where they're bringing in nursing assistants and the charge nurse and the nursing supervisor to specifically talk about patient issues that arise, and they get everyone on the team together. But in terms of including the family, I think now both in long-term care and in rehab facilities, the family members and the caregivers, it's a huge part of the discharge planning now.
And Tom, I would think that would be relevant in reference to working with some of your clients in the anticoagulation center with caregivers.
Oh, yeah, it's a main emphasis with what I do, because the average age that I have is late 70s, 900 patients. So on our referral, we always ask for caregivers, POAs, certified nurse practitioners that might be working with the patients. I have a lot of patients that are in the home and have caregivers for like 8 to 12 hours a day. So I'm often communicating with them because we have to coordinate who's filling their pill box, when is their INR due, what new medicines they're on. And then we have nurse visits, which are key. They usually come at least once a week and try to coordinate all that. So that's a routine part of my practice, to know who's in charge. Oftentimes when I talk to patients at discharge, especially new referrals, they'll often say, I don't handle my medicines, and then it's my daughter, my son, or someone else. And then once I have that contact and permission from both, then all dosage changes, all letters that I send out would then go to the care provider. Some patients don't want to know that someone's looking over their shoulder, so I have to mail a letter to 2 different people, or I call the patient and then also call the caregiver. But it's critical. We have patients on warfarin that need INR testing. So an example of location, I have a lot of patients that live on islands, can't get to where we are for blood tests. So now that's where technology comes in, where we now have a meter that the patient can actually test themselves, or I have a caregiver, a son or someone who goes to visit and does that INR testing for the patient, and then they can call or put the results in the internet. So I have several patients on Tangier Island who have to commute for lab work, but they can have that point of care testing done there. And that has to sometimes be done with caregivers. So oftentimes med updates, caregivers, emails, phone messages from people that take care of them is a critical area in the antithrombosis area. And from back to the nursing question, I think the challenge for all of you that are looking at nursing as what subspecialty you want to be in is, I would second what Dr. Burton said, you just can't get away from the volume of medication that these patients are on. And it changes daily, the types of medicine. And you got to realize the research we do, most research we do, if you're over 75, you don't get into most clinical trials. So the clinical trial is the nurse assessment of the patient in the home, calling me about problems. Readmissions are an issue, so we have actually a nursing team at Shore Health System that for heart failure and I think COPD and maybe dialysis patients, to prevent readmissions, a nurse goes in, it's called wellness, and they oversee the patient, and they'll be calling me saying, did I know there were certain med changes? So I think continuity care is an issue now in our community, as we all know. So we don't have the continuity care we had back in the 70s. We don't have the same family medicine doc taking care of all of our issues. So I find the continuity care oftentimes is sometimes a nurse who sees that patient on a routine basis, as long as we have reimbursement and have the ability to have the nurse go in the home. So that's really, I think, a challenging part is the assessment, but also knowing that the volume of medications these patients are on, I just mentioned, average of 15, 20, 25. You can imagine the task for a nurse assessing these patients. And when they come in the hospital, big issue is what do they come in on? We spend time reconciling their medications, what they go home on. It's really a major area for nursing. And I speak from personal experience because my wife is an ED nurse. So I hear all the issues about people coming in and the problems with medicines, especially in our aged population.
Thank you, Tom.
Sure.
Did you have a question, sir? I'm sorry.
When Dr. Burton, am I pronouncing your name right, sir? Dr. Burton? When you talked about the judgment, how important it was on an individual basis, and that as part of that collective group in the caregiving, going back to the question that was raised a minute ago about the caregiver, who better could be familiar with the personality and the characteristics of the individual that you were talking about and how important it was to relate to that? It seems to me, it sounded to me like Dennis's response was more silo. I mean, you included the caregiver, but he didn't sound like it was part of the group.
Yeah.
Neither did your response sound like it was part of the group. And this whole issue is about the teamwork, and it strikes me the caregiver, while they're not the professional and the educated, have an awful lot to bring to the table. Am I right about that?
Yeah, and I think just from Dennis and Tom's response, when we think about caregivers, we think about formal caregivers and informal caregivers. And formal, I think they were thinking more of the GNA, CNAs there. Whereas the informal caregivers that we often see in our primary care practice are neighbors, family members, parish members, church members that come perhaps with them. And exactly.
Yeah, so I would just comment to try to get at that question by making the comparison with pediatrics. Geriatric medicine is very similar to pediatrics with respect to the team approach and with respect to the involvement of the caregivers. It must be because of the vulnerabilities, different age, different vulnerabilities, young from old, but the concepts are the same. You can't take care of an older person, a real older person, without the caregiver being involved. It's all about reason, it's all about judgment, and that's sometimes incredibly difficult when there has been family discontent. But very often that brings out the best in the physician and the nurse and the social worker to bring them together for the common good of the individual patient. So it's all about the team approach. It's all about the patient plus that support group. How can we help? You cannot care for someone, for example, with advancing dementia without keeping an eye on the caregiver. They're taking the burden. They're as much a patient as the individual. So it's all about that, in my view, and I find that absolutely a rewarding part of the clinical practice, the education of the caregivers and the explanation to them. If they burn out, everything comes apart.
Definitely.
Thank you. I think we have time for one more question.
So my question is for team, we obviously need chemistry. How exactly does that build up between all you guys? Do you hang out?
twice a polka, I don't do that.
So, yeah, I just,
Dr. Burton, did you
so
have a
I
comment?
think the question relates, if I've got it right, how does the team huddle, that kind of thing? So it's all about efficiency. Each team has its unique chemistry. And part of the problem we've gotten into in medicine over the last several decades is the teams are not teams. They're component parts. They're interdisciplinary, but they're not working together. So it's that partnership, the team, and it has to be effective, it has to be efficient. You absolutely have to keep track of the time in the huddle, or you drive up costs. So it becomes specific to the group. Jane Marks and I have a very classic kind of relationship. We're communicating all the time, sometimes together, sometimes by email, sometimes by text, every conceivable way about almost any issue. Other teams, for example, the Program for All-Inclusive Care, which is totally team care for a very vulnerable population of patients, nursing home eligible but living in the community, they have a huddle of about 20 or 30 minutes every morning and deal with what's happening with the situation. So each team is specific, and you all will work on teams, and you'll be part of how do we make the best out of this team, how do we make it efficient, how do we focus on what needs to be done.
But I really think you have to keep in mind that every team member brings an important part. And so listening and communicating is vital. I know with our anticoagulation patients, we work well with the pharmacist that runs our program. We're in constant communication if there's a medication change, make sure that there's no adverse drug reaction. And in turn, he always responds to us with issues that he sees. Same as working with our home care department and working with patients that perhaps are getting home physical therapy or social work, working with them. So I think it's just that communication part too, and respecting each other and taking in their opinions as well as their guidance and working with them. And I just have to say one word in reference to Renee's comment about the GNAs and CNAs. I have to tell you, they are the eyes and ears in most facilities of things going on. So respect of them and listening to what they have to say, because oftentimes they will be the ones that know patients very well because they've cared for them for a while. And they can let you know that there's a change or something's just not like their usual. And so listening to them and, you know, taking in their information and then assessing the situation, I think is vital. They're part of the care team as well in any type of facility, and as well as doing home care, because they do home care as well.
And Jane, can I add one thing? The most important person on the team is the resident, is the patient, okay? Whether you call them a client, customer, whatever, that's the most important person. And everybody else, the doctor, the physical therapist, social worker, everybody, you know, we have to see what's in their best interest and what they want. You know, I think it's an advocate for them. Sometimes what we want, what they want, might not agree. And you might hear a term in nursing homes called culture change, even more of that, where they're really trying to make the nursing homes, I think assisted livings are kind of already there a little bit, but nursing homes, so much a medical model where, you know, we tell someone your shower days are Tuesday and Saturdays, and we serve breakfast at 8 and lunch at 12 and dinner at 5. But how about if I want to sleep in until 10:30 or 11 o'clock, and I don't want my meal till 11? Can you accommodate that? It hasn't been that way. It hasn't been, it's like, nope, yeah, if you missed your meal, back till next meal. Oh, well, you know, and it wasn't what the resident wants. It's been at the convenience of the staff, you know what I mean? And the medical model kind of thing. And there's really a push, and I hope it happens. I see it happening in some facilities, not as much as I like to see, but make it more of that culture change and make it more like we like to live, you know what I mean? Because that will give them the best quality of care and quality of life if that will happen. But again, the most important person is that person we're taking care of.
Thank you, Cheryl. We have just one more question we're going to fit in.
Great, now I'm the guy who
It's
makes us stay
burning.
late on a Monday night. All right, I don't know much about the hospital at home care, but I did come across 2 studies of Dr. Burton's that concluded that the patient satisfaction is increased without actually increasing stress on the family, which seems like 2 great things for geriatric patients. So my question is, I'm curious, what role, if any, do you think hospital at home care might play in the future of geriatric acute care?
So what role?
Hospital home care. So
Hospital.
hospital at home, is that what you're talking about?
Yeah, it's,
So-
there was
so
two
the
studies.
concepts there are, I believe strongly in home care. We need to develop it in a very much more robust way. It's been thought of as kind of a silo. Nurses out there doing care of patients, not really connected physician. That's okay, but it doesn't work well in the older population. So all kinds of new and creative home care teams, fundamentally an extension of the hospital. And the modern hospital is not going to look like the one that you're in now. It's going to be really connected much more tightly to the community. One example, a project that we've been working on for 20 years is Hospital at Home. So you take patients who are ill enough to be in the hospital, but have the ability to care for at home. So nurse goes home with patient, docs are seeing patient at home, care is provided at home until you're stable enough and can be discharged. Congestive heart failure programs are tightly connected to the hospital and are team-based, home-based care of how do you keep the patient stable and out of the hospital. So those are the models that you all will think of and help participate in the development of over the next decade. And I think 10 years from now, Mary, when you have the next symposium, the subject matter will be very, very different because of your input to it. Thank you all for being here.
Thank you. You want me to thank you?
I didn't hear it.
Thank you for coming, and we hope to see you next year. It's an exciting time, and we hope at least you got a piece of the team effort and can carry that in through your practice.
Thank you, Jane.
Thank
Thank you, Jane, and thank you to our panelists. We really appreciate you coming and sharing your expertise.